on gender dysphoria. We'll just give another couple of minutes just for the last people to join us. Just a reminder that if you do have any questions during the workshop, please do put them into the chat bar facility and we will monitor these throughout the presentation. So just another couple of minutes before we start. Okay, my time says it's now 3:30, gone 3:30, so we'll make a start. Welcome to Medical Needs in Schools Suffolk workshop today on gender dysphoria, presented by Dr. Carla Cantica. Just a reminder to use the chat bar facility with any questions. Please do put them into the chat bar and we will monitor these throughout the presentation. I'm just going to do a very quick introduction to our presenter this afternoon. This is Dr. Carla Cantica. She's a paediatric junior doctor in her 3rd year. She's worked in Wales, the Midlands, and in the East of England, and is currently doing neonatal medicine in Norfolk and Norwich Hospital. Carla has a special interest in supporting mental health. I first met Carla while she was working at Ipswich Hospital after she had delivered some departmental teaching to colleagues on gender dysphoria. She readily agreed to share this teaching with us, and we are very grateful to her for giving up her time today. Over to you, Carla.
Hi everyone, good afternoon. So as has already been said, my name's Carla. I am a paediatric doctor. I'm working in NICU at the minute. So I developed an interest in gender dysphoria and sort of transgender issues when I was in medical school. I've sort of tried to keep up to date with it. I will say I'm not a psychologist or a psychiatrist or an endocrine doctor specialist, but I have done a bit of reading in the area. If you have any questions, as has already been said, feel free to pop them in the chat box while we're going along. So hopefully everything will work technically, and you will see my next slide now. So this is what I'm going to be talking to you about today. So a lot of this presentation and talk will be definitions. A little bit of that will be because the language that we use is really important and the definitions are changing really quickly. And I'll explain a little bit about how they've changed in recent years. I'll tell you a little bit about what we look for, how we would go about diagnosing gender dysphoria or gender incongruence, our management strategies, and then I'm hoping that I'll give you a helpful list of resources, so places where you can send kids and parents of kids if they're struggling with these issues. I think that's probably my most important slide out of all of the slides that I've got today. It's a collection of charities, etc. So hopefully that will be helpful for you guys. So one of the first helpful definitions when I started doing reading about this is what actually is gender. So the original meaning of gender goes back to an old Latin genus, which I'm sure you guys are all familiar with a sort of kingdom, phylum, genus definition that you guys teach in schools. So it is to do with sort of like French gender type language, so certain words are masculine and feminine, and it wasn't until around 1950 that a sexologist started turning it into this social and cultural role that sort of then defines how we see masculine and feminine. This changes depending on the setting. It changes depending on the country and even the time that you're in. So if you think about 200 years ago, now we see pink as a female colour, but sort of 200 years ago it was the other way around. It was blue was the female colour and pink was the masculine colour, but that's changed now. And this whole idea of having a binary gender system in certain cultures is more fluid than that. So the Hijra people in East Asia, they have an idea of somebody who is a third gender. It's similar for Hawaii. They have an idea of a sort of something in between male and female. And there is also the Two-Spirit community in Native American population that sort of, again, create this idea of a third gender or sort of like a gender spectrum. This is something that's kind of, it's unusual in Western cultures. It's something that's gaining popularity now. I'm sure you guys have all seen it. It's in the newspapers. It's talked about a lot. And I think that that is a good thing, because it means if it's talked about more, it's more sort of mainstream. And I think that is the way that a society progresses. So your assigned gender is the gender that you are given at birth, and there's lots of things that contribute to that. I know that sounds a bit silly, but from a medical perspective, you can have underlying medical problems that even though you look like a boy, for example, externally, you may not be. So assigned gender is that sort of social role that you're given at birth. And then your affirmed gender is then the social role that you feel yourself to fill. Different from both of these, and very importantly distinct, is so that our of sort of what you are in a way. It's also called the natal gender, so your birth gender, sort of like the biological hormones, chromosomes, external genitalia, etc. So then gender incongruence is when there is a difference between your assigned gender, so the gender that your parents picked for you or that you were from birth, and then the gender role that you feel yourself to fill. And this is different now from gender dysphoria. So gender dysphoria is the psychological fallout from having a mismatch of the gender role that you're assigned and the gender role that you feel yourself to be. This sort of psychological impact has to be present throughout a variety of settings. So that includes home, it includes school, friendships, relationships, and this has changed recently. And it's in the process of changing. And the reason that this is important is mostly for sort of a stigma, from a stigma perspective. So the ICD-11 and the that's ICD-10 at the minute, and the DSM are like a diagnostic framework that we use that give like a category for diagnoses that we give to people. Gender incongruence, so that difference between your assigned and affirmed gender, has been moved out of a mental health problem, and it's now been moved into a different category, into a disorders of sexual health. So this will officially come out in 2022, so that's when it will all sort of officially change, but obviously we need to just lay the groundwork for that before it gets there. The reason for that change, you know, if we think sort of 50 or 60 years ago, we had homosexuality as a mental disorder, and now we look back and we think, how could we ever have thought that? But it does still allow us to put a diagnosis on that difference. So a lot of better if they have a diagnosis. I think medicine has a lot of uncertainty in it, and I think if you go to your doctor and you say, I'm uncertain about this, and they can give you a title, it's part of the treatment process almost. And in hospital, it's helpful because there are certain biological differences and hormonal differences and anatomical differences we have to consider when making our diagnoses if we know that somebody is gender incongruent or transgender. A lot of places are yet to catch up with this change in definition. So if you were to Google gender dysphoria, probably about 30 to 50% of the results that come up will still be using the archaic definition, which is that gender dysphoria is this mental health problem that says that you have a difference between your assigned and affirmed gender. And I know it seems probably a bit nitpicky, but I think a lot of people in the community feel that it's a very important distinction. So in terms of what causes gender incongruence, we don't really know an awful lot about it. So we know a lot about your sex development, so your biological hormonal processes. So those abbreviations stand for congenital adrenal hyperplasia and androgen insensitivity syndrome. So I think there might be another possibly talk about those. Anyway, it's hormone pathways that then define how we develop our sexual characteristics. So your external genitalia and your voice dropping and your Adam's apple and etc. But in terms of gender development, we don't have very much really good solid evidence for how it happens. And so because of that, we don't have good evidence about why gender incongruence happens. So as for gender dysphoria, which is this psychological fallout from this gender incongruence, most of it comes from the fact that how you choose to express your gender quite often has a negative kickback from the society that you live in, especially, I mean, from all over the world, but especially in Western societies. And it's that sort of mental health kickback that we then have to learn how to deal with. So the presentation of gender incongruence or a true transgenderism is mostly an adult diagnosis. So in 2010, the mean age of presentation for somebody who was gender incongruent was 42. And it is a bit of a political hot topic at the minute. It's spoken about a lot in mainstream media, in the news, and it's also not quite as big of a problem as it's made out to be. So about 0.6% of US adults identify as gender non-conforming. Now, gender non-conforming does not mean that they are transgender. It means that they do not agree with the typical binary system, so man and woman, that the way of expressing gender and how you fulfill those societal roles can then become more of a spectrum. And actually, one of the biggest pushes for this sort of in the 70s was the feminist movement, because you then start, I mean, at that point it was women can fill the roles that men are traditionally filling, but now it's starting to go in the other direction of men then being able to equally fill some of the roles that women can traditionally have been filling. I haven't put many statistics on this slide because some of the numbers that I found were quite outdated, and I think it's changing very rapidly. So the group most likely to identify as gender non-conforming in this 2010 paper that I looked at were 18 to 24-year-olds. Now, you got to add another 10 years onto that now, because we're in 2020 now, and I think probably the layout is going to be very different now, because it's spoken about more and people feel more comfortable, maybe because it's more mainstream, to now externalize this sort of gender non-conforming maybe view that they might have. And it's spoken about earlier. And this is a good thing because earlier recognition of problems with gender identity can prevent a lot of the psychological fallout. You know, things like suicidal behaviours, self-harm, developing body dysmorphia, or, you know, risk-taking behaviours that a lot of teenagers with significant mental health problems partake in. So this is probably the second most important slide in this presentation. Having gender dysphoria or gender incongruence as a child or young person does not mean that you are transgender, and it does not mean that you will carry on to be an adult who is transgender. So about somewhere between 6 to 13% of people who are gender incongruent as a child or young person will have that feeling persist into adulthood. So that 6 to 13% accounts for gender differences, sort of the base gender differences. And what I found really interesting when I was looking at this is there's a number of small limited size studies that found a higher link to things like homosexuality and body dysmorphia in children who were I'll give you the references at the end of the slide, sorry. Found higher rates of homosexuality and body dysmorphia than for transgenderism as adults. And it's not until they're much older that we start thinking about actually considering managing them as being truly gender incongruent or transgender. And I'll talk a little bit about that in a moment. I don't think I really need to have this slide here, honestly. I think all of you can probably appreciate why it's a problem. The significant mental health impact of being gender incongruent, and then the social fallout from that causes really high rates of homelessness, much higher rates of HIV infection compared to the general population, because they have a really high rate of risk-taking behaviour. They're much more likely to suffer physical violence compared to the general population, and they have higher rates of substance abuse. So these figures are taken from an Irish study, which I'm sorry, I don't think I actually have in the references. I will come back and put it in later for the slides that we put up on the website. But 30% of base male to female transgender adults and 50% of female to male transgender adults have at some point attempted suicide. And that figure was, when I read that was astounding to me. That was it was a really hard-hitting fact. And I feel like if we can do something about it earlier, maybe we can stop people getting to this crisis point. So sort of trying to get to grips with what's causing this gender dysphoria can be quite troublesome. These are questions you guys are not going to be asking in schools, I suspect, because they're probably quite personal and have a certain amount of medical swing to them as well. But the most important thing that we can do is be non-judgmental and receptive to the answers that are given. So timescale is important because we don't even consider a diagnosis of gender incongruence or gender dysphoria unless the significant effect has been going on for more than 6 months. So it has to be pervasive, and it has to be sort of affecting all aspects of things like home life, school life, interaction with peers, interaction with teachers, and relationships. I'm also sure most of you can appreciate that if you have significant mental health problems, your personal care, your self-care does fall off, and that's important to ask about. And I don't just mean things like, brushing teeth and brushing hair, especially in the older young people, so the teenagers, you start thinking about things like risk-taking behaviour and substance abuse. And you have to talk to them about sort of plans for the future and their ambitions and things, because if they're really struggling with their self-identity and they think, yeah, they get into this place where they just think there's no life for me in this society and there's no way I can carry on. So it's important to ask those questions. And in the older group, then exploring sexuality is important because of the previous slide. Because that can help get to grips with why they're having problems with their sort of gender role, and also then their feelings towards their gender specific features. Now, I've got a link on the second to last slide for the gender identity services, the Tavistock and Portman Clinic, which is our centralised service in the UK. It's got a lot of really good testimonials for people who've been through the service. And one of them is a young lady called Adrian, who spent a lot of time being assessed by the Tavistock, and she had a lot of sort of symptoms of hatred towards her gender specific features, and she was diagnosed as being gender incongruent, and as such started this period of transition when she was 17 or 18, and she went through 18 months of transition and living as a male. And through that 18 months with ongoing therapy and assessment, they realized that her problems were more related to feelings of gender dysphoria, body dysmorphia, so hatred of her own physical features. So it wasn't so much that she had problems with her gender, she had problems with the fact that her weight meant she had very large breasts. I know it seems like a very difficult distinction, but the difference for her in that situation was that she didn't really want to go through the transition. She needed help with her views about her own body, and that therapy then helped her with that, and helped with a lot of the sort of psychological fallout. So our management really in the UK for gender identity problems is through the Tavistock. So that it's based in the Tavistock and Portman NHS Foundation Trust. And early referral is really helpful because a lot of, I think maybe GPs and probably quite a few doctors in district general hospitals won't necessarily have the skills available and resources to be able to assess people and then offer appropriate therapies. So there's a centre in London, there's one in Leicester, I think there's one in Liverpool, and it's not just sort of sitting down with a therapist and talking. There's reams and reams of assessments and months of really intensive therapy. And one of the mainstays is something called DBT, so dialect behavioural therapy. It's kind of like CBT, cognitive behavioural therapy, but it's sort of a combination of that and a bit of mindfulness, and it sort of helps these kids with a coping mechanism structure on how to deal with when they have emotional crises. And then obviously we have medical therapies for the psychological fallout, like anti-anxiety and antidepressant medication. And I'll talk on the next slide about the hormonal therapies. And another really important treatment is really the family-based therapies, because a child or young person is not in isolation, and there are situations where the family situation can make things much worse for them. And that's where the Tavistock team are really helpful as well, trying to just get to the bottom of what's going on. And in terms of management for the general population, just one of the most important things we can do is get the pronouns right. I know this makes people really nervous, actually. I think when you're talking to somebody who has gender identity problems, I think it puts people really on edge and they're worried about making mistakes. I think it's a bit like if you're talking to somebody for the first time and you forget their name, and it's much worse to say their name wrong and rather than sorry, it's much worse to say their name wrong rather than to ask and get them to tell you what pronouns that they would prefer. Yeah, so Jess just made a very good point in the chat. So the waiting lists for the Tavistock Clinic are really long because it is like I said, it's something that's becoming more prevalent and more people are more aware of it. So what I've got on the last slide is a bunch of charities and support groups that you can be referred to sort of as an interim measure while you're waiting for your referral for the Tavistock to go through. And I mean, I know it's not ideal, but it is it's something that we can do, and that makes it even more important. That 36-month waiting list makes it even more important that, when we identify this, that we refer them early. So this is so the hormone treatment bit, I think, is something that is another sort of fairly political topic. We do not make that decision in a district general hospital like Ipswich. The people who make that decision is the Tavistock. So the hormone transitioning treatment that we don't really do for people under 16. It's incredibly rare for us to do this in under 16-year-olds. What we do for those who are under 16 is offer them puberty delaying medication. So I'm sure that you guys have all heard of this because it's been in the newspapers recently. It's called a GnRH analog. You don't need to know about that, but it's something that we've been using for a really long time in treating prostate problems and treating things like endometriosis, because what it does is it stops your pituitary, so a gland in your head, from producing the sex hormones that define your sexual characteristics, your secondary sexual characteristics. So by that I mean things like facial hair and your voice dropping and things that happen during puberty. And what the GnRH analogues allow us to do is basically halt the development of those secondary sexual characteristics. It's worth mentioning we've also been using this for a really long time in sort of 7 or 8 or 9-year-old children where they go into puberty early, and we give them this medication to stop that from happening, to allow them to grow a little bit. So we already have quite a good evidence base before we started using it for gender identity problems of side effects and dosages, and we know it's a fairly safe drug, which is reassuring. That being said, we do know that there are some effects of delaying those sex hormones on your bone mineral density, so the strength of your bones. And we don't really have that much evidence on what delaying those sex hormones do to the development of the adolescent brain. We do know that kids who do go into precocious puberty, so early puberty, have a much higher rates of things like risk-taking behaviours. So but we just need more research on what that effect is on the brain as they get bigger. So the regret for reassignment surgery and hormones in the adult population in Western Europe is about 1.8%. And I think that is that's a very high number after having gone through surgery and what can be quite problematic hormonal treatment. So this is why, with the knowledge that gender incongruence and gender dysphoria often doesn't translate to being transgender as an adult, we don't rush in to hormone replacement in children, and we delay puberty to stop them needing even more surgery and treatment to reverse the effects of those the sex hormones developing their secondary sexual characteristics. So this is one of my favorite slides. So I guess this is all fine and good, these stats and things, but the real question is, how can this be used to help my students? So like I've mentioned, one of the most important things is just asking how they want to be addressed. I think it's important because it shows that you are receptive for how they are wanting to express their gender. And that takes many different forms for different people, whether that is living as the opposite gender, or whether that is just taking presenting features of certain genders. And the other thing is you will spend a lot of time with your students, probably more than anybody else does, and you will probably be some of the first people to notice signs of social withdrawal, signs of self-harm, that they're struggling with their grades or with their interaction with students and with teachers. I'm gonna hold my hand up and say I don't know what the referral process is like in schools for when you're worried about mental health problems. We were talking about this with Laura and Kate, and we thought probably the sort of your safeguarding lead might be a first port of call, but that is probably more when they're in extremis. But it's really, the sooner that we can start the referral process going is better, basically. The referral to the Tavistock is preferably through a GP, because then that central service has a community service to refer them back to for their ongoing management. But you can do a self-referral through the Gender Identity Services website. I think the fact that you are all here probably means that being open and receptive to people expressing their gender is not a new concept to you, but I wanted to show you guys a little bit about how gender incongruence does not necessarily equate to being transgender. So the top two pictures are the presenter for the Straight Guy on Netflix. He was one of the first men to grace the cover of Cosmo magazine since I think 1984, when I think it was Sean Connery or something like that who did it before him. And he beautifully, I'm very aware of the fact that Jonathan is somebody who is a big advocate for a non-binary, more like a gender fluid system, but I'm using he just for ease of communication. The fashion, the way that he expresses his gender is just brilliant, because he has beautiful flowing shiny brown hair, this manly beard, and he'll wear florals and ruffles with combat boots, and I just think it's a really, really good way of expressing your gender identity. At the bottom here is somebody called Crystal. So she is a contestant on BBC's RuPaul Drag Race UK season 1, and you would think that a drag performer, so dress resembling a girl, drag performer would be hyper feminine when they are performing, but the UK drag scene is a bit different from that, and it's very much taking aspects of masculinity and femininity and sort of combining them in a slightly unusual way. with a hairy chest and hairy underarms, but still with this beautiful, extravagant makeup. And it's all about just gender expression. And this person here is called Adam All. So they are a drag king. So they are a woman who performs as a man, and they perform in London. And I just wanted to include them because it's not just men taking aspects of femininity, it goes both ways. And for a really long time, we've been using external features as a way of expressing our internal views. And I think, again, with what I've mentioned, that being gender incongruent or having gender dysphoria does not mean that you are transgender. It just means that you are struggling with the roles that society has given you. And one of the most important ways that we can help them with that, we can help people with this, is to allow them the freedom to express this. And, you know, we think back to the 80s when the punk movement was happening, and you would see people like that walking down the street and you would be afraid and walk away and go, you know, and there was rates of violence against people who dressed in like a gothic way, and it sort of expressed themselves that way. And now looking back, that was all a bit backwards, and we just don't really agree with that kind of, well, I would like to think that largely society thinks that that is very backwards now. And I think we just need some time in the West to adjust to a sort of slightly maybe more gender fluid scenario. So some of the places that you can send your children and young people if they're struggling with gender identity. So the best place is the Gender Identity Services. So that's the Tavistock Centre. That has referral pathways, but it also has FAQs and patient testimonials, both people who have gone on to transition in adults and also people who haven't. So I think it's just a really good resource. So TransWiki, so I'm going to addendum this and say that this presentation was first made before COVID, and TransWiki is a like a directory for support groups in person. Unfortunately, I'm sure they have other ways of doing it now, but support groups for people who are going through transition or struggling with gender issues, and you can organise the UK by area. Mermaids is a transgender charity that worked with Starbucks recently, well, a few years ago. I don't know if any of you guys saw. They were selling mermaid tail cookies to sort of increase the awareness of transgender issues. And quite often the first place that people try their new identities and new names will be by going to Starbucks and putting their name on a cup. So the other helpful place is youngstonewall.org.uk. So this is for all LGBTQ young people, and it's just a charity with support basically available to you and stories and testimonials. Minded for Families is, I think, just a good resource to have for anybody with mental health. So it's not specific to gender identity problems, but it's basically a website for parents of children who have significant mental health problems, basically for support. And pinktherapy.com is a UK organisation to help link you up with therapists who specialise in gender diverse people of all ages. So I'm hoping that those are some, I think I'm just seeing in the chat that some of you guys have seen some of these resources. I'm hoping that some of them are new and will be helpful as well. The other thing is that this is not a process for children who are in crisis, children or young people who are in crisis. If you feel that they are in crisis and a danger to themselves or others, then they need appropriate referral through the normal mental health channels. So A&E if required. The Health and Wellbeing Hub is also a good place to refer. And I'm just seeing in chat as well that apparently Tavistock will accept referrals from school staff as well. So these are all of my references. The article at the bottom is a really good summary article, and just has some helpful information in it if you're sort of trying to just educate yourself a bit, which I found really helpful. And the rest of them are sort of articles where I got some of my statistics from. I don't have the article that I got the statistics for the Irish study, and I will find that article again and put it in for you guys for the slides that we put up on the website. Thank you all very much for listening. I would welcome any questions. I'll do my best to answer them.
Thank you, Carla.
Hi. Oh, sorry.
Oh, yeah, no, please join in. Go ahead. Go ahead.
No, it's Sonia here. I'm a school nurse. I'm just wondering, can a paediatrician make a diagnosis of gender dysphoria, or does that have to come from the Tavistock as well?
So that's a very good question. I think that it would depend on the situation. What we would probably say in our referral letters, for example, is sort of suspected diagnosis or like presumed diagnosis of gender dysphoria with the referral. I think probably by the time they're getting to the Tavistock, they've probably got that gender identity problem sort of as a reason they're going. So I think they could probably, you know, so the formal diagnosis would probably come from the Tavistock, but you can start putting labels on things before they get there, if that makes sense.
Yeah, it does make sense. But I'm just wondering, is it worthwhile, considering the length of time they wait for the Tavistock, for parents to help get the ball rolling in a way with using the paediatrician? Because that's not generally discussed with a GP. Usually it's GP straight to Tavistock, cut out the paediatrician. Yeah. But I'm just wondering if that's a route worth taking.
Yeah, so I mean, the first reason why I would say possibly not so helpful is because I don't think that the majority of district general hospital paediatricians will have a huge amount of understanding about this. And I think that probably even your sort of most of the therapists that like the child and adolescent mental health services can offer probably won't have a huge amount of understanding about this and will feel a bit out of their depth.
Yeah.
So it's a very good point, because that waiting list is significant, and I'm very aware of that as well. And that, I mean, that's the case for the CAMS services as well, any mental health services, just you know, avoiding the gender identity problems.
Yeah. Okay. Thank you.
So what training is there to improve GPs' understandings is one of the questions. So the Tavistock do so I think their yearly sort of training, like conventions, I guess, where they do updates and training and that kind of thing. Other than that, I'm not super aware of any courses, but what I can do is do some reading and find out and come back to you with some courses, if there are any available in COVID world for GPs training.
I think what we're going to find more and more in schools are the mental health fallouts, really. And I think that with more and more people trained with mental health first aid, I think that's also a good referral route. So for us in schools, if we certainly know that the LGBTQ plus group are overrepresented on the wards in Ipswich Hospital, and we know that there's a direct link between those struggling with identity and sexuality more likely perhaps to have feelings of suicidal ideation. Anybody that has done the Mental Health England First Aid course will be able to help with the signposting as well. So in that interim period before the before the referral process has been taken up at Tavistock, then don't forget your mental health first aiders to help, and also those wonderful resources that you've put at the end there to go directly to those websites. I think they were really useful to us in school, so thank you very much, Carla. If there are any other questions, now is the time perhaps to be popping those in the chat bar. I see that Jess is asking, are there any recommendations of protocols for schools to follow around toileting, toilet residential sleeping arrangements?
So yeah, I was kind of dreading somebody asking this question because it's an excellent question. I only know no, that's all right. I only know for sure that places like Kesgrove High School, for example, which is, I mean, I appreciate it's a secondary school, but they have mixed gender toilets where they all have cubicles. So it's not, they don't have like a urinal, it's just the whole, every toilet is a cubicle. So that's one sort of thing, that's a way of dealing with that that's emerging. Now the residential sleeping arrangements, I'm not sure about, basically. I think it becomes a very difficult and contentious issue, and that's not just for children, it's for adults. The use of mixed gender toilets is hotly debated, and that's something I don't think we're going to have an answer to easily.
Yeah, I think you're right, Carla. I think it's up to each individual school after lots of soul searching and discussion around the subject. I do know that Felixstowe Academy in their rebuild had gender neutral toilets that people can use. So I think generally it's up to the school individually. I've been asked a question about the mental health first aid course. So if you are a medical needs in schools partner school, then once you've sent your self-assessment, self-evaluation form back, then I will make an appointment with you and we can discuss all your first aid requirements then. I hope that answers your question, Sherry. And Jess has said it would be so great if Suffolk could draw up guidance and advice for schools other local authorities have. I suppose it's to watch this space, Jess, and perhaps for your own school, have a look at what the other local authorities say. It's really good to see school nursing join us today, and thank you very much for reminding us about the school nursing referral route.
Thank you. Plug.
And Carla, are there any other questions? It's been really interesting, really thought-provoking, excellent information, so much to take away. So thank you so much. We are going to have to draw to a close now, everybody. But is it okay, Carla? I know you've said all right that we can share your PowerPoint presentation on our website, because there was a question earlier about sharing that. So we'll pop that up on the website with your permission.
Yeah, that's absolutely fine. What I'll do as well is I will I'll make sure that Kate and Laura, I mean, they have my contact emails anyway. If Kate and Laura, if you have any questions or anything like that that you want to ping to me, I should have put my contact details on this presentation really, but if you've got any questions, just ping it to me through them. I'm very happy for that.
Okay, thank you very much. We will make sure that your details are up on the slide. Thank you for that. And for everybody, that our next workshop will be next week at 3 o'clock on, I didn't put the date down. It's on self-harm. It's going to be delivered by Dr. Isabel Paz, a consultant psychologist from Oxford. And it's next Tuesday, the 8th of December at 3 o'clock. I apologise for the early start, but that's the time that Dr. Isabel Pad can give us. But we will, as always, record and put all of our workshops up on our Medical News in Schools website, which is obviously through the Radwell Trust Outreach Services website. Many thanks again, Carla, and thank you everyone for joining us. Bye-bye.